Hello. In this video, I'm going to demonstrate how to perform the core exam on yourself during distance learning. Of course, if you have a family member or a roommate that you can practice on, please perform the exam on them. We have 3 objectives for you. Number 1 is to develop the hand and motor skills in order to perform the physical exam. Like any sport, through repetition and deliberate practice, your physical exam skills will get better. Secondly, we want you to start develop a sense of what a normal physical exam is like. Of course, we presume you yourself have a normal exam. And this is going to be through knowing the surface anatomy, as well as knowing what normal heart, lung, pupillary reaction are like. Our last objective for this session is for you to start to use the tools and the equipment that is associated with performing a physical exam. And whatever equipment you use will be germane to the patient's complaint. Please practice in front of the mirror or the camera of your computer so that you get a visual feedback of you performing the skills. Remember that if you are using a mirror, as this video demonstrates, account for the fact that it is a mirror image.
Welcome to the Doctoring 1 core exam video. The core exam is the very brief screening exam performed on all patients regardless of their presenting concern. After washing your hands, begin the exam by briefly observing for signs of distress, discomfort, and level of nourishment. For the external eye exam, make sure to use a light source against the wall or using a pen light. To visualize the scleral conjunctiva, pull down on the lower lid and have the patient look up, then pull up on the upper lid and have the patient look down. You can do this one eyelid at a time or simultaneously and have the patient look up and then down. Doing it simultaneously may also allow better visualization when the patient looks side to side.
You can look at your conjunctiva by pulling your lid down and look at the mirror. And then pull your lid up and look at the mirror. And then swap sides. Look down. And then look up.
When checking for pupillary reflex, ask the patient to look into the distance and shine a light obliquely into each pupil in turn. Observe for both direct and consensual pupillary reflex.
You can check for a pupillary constriction, shining a light in your eye obliquely and look for constriction and make sure the other side's constricted too, and then switch sides. That's direct, and then look for the consensual response.
For the oropharynx exam, again use a light source as well as a tongue blade. Use the tongue blade to push down on the tongue to better visualize the rise of the uvula, the tonsils if they're present, as well as the posterior pharynx. You'll also want to use the tongue blade to push against the buccal mucosa on both sides and observe the gums and the buccal mucosa. Finally, ask the patient to lift up their tongue.
You can practice the oropharyngeal exam by using a plastic spoon or a plastic knife. If you don't have a tongue blade, or if you have a popsicle stick, you can use that too. Shine the light on yourself. And I see the uvula elevate. Use the spoon to pull my cheeks to the side. And lift up the tongue.
When palpating lymph nodes, use the pads of 2 fingers with a gentle rolling or rotary motion.
You can do a lymph node exam by cell palpation. Look in the mirror, preauricular, posterior auricular of the mastoid, occipital, posterior cervical, supraclavicular, anterior cervical, submandibular, and then submental.
When auscultating for heart sounds, have the patient in a sitting position and ask the patient to remove the shirt or lower the gown so that you can adequately assess the positions. After confirming that your stethoscope is in the diaphragm position, palpate the sternal notch. Just to the right and below it is the right second interspace. This is the aortic area. On the other side of the sternum, in the left second interspace, you'll find the pulmonic area, and as you go down the left sternal border to approximately the fourth or fifth interspace is the tricuspid area, and laterally to nearly the midclavicular line is the mitral area. For some women with pendulous breasts, you may need to ask her to lift up the breast in order to listen to the mitral area.
Remember, when you're sitting in front of the mirror, it's a reflection so that your right looks like it's your left. Okay, locate the sternal notch and then move down. You feel a little tiny protrusion. That's manubrium. And then lateral to that, you feel a little divot. That's the second intercostal space. And on your right side, that will be where you listen to the aortic valve area. And then to the left side of the sternum, in the divot, which is the second intercostal space, that's the pulmonic area. And then you go down, this is number 3, and then one more, that's the fourth intercostal space, and that's the tricuspid area. And then you go down here, midclavicular line, where I would have to lift up my breast. This is the mitral valve area, and it's about the fifth intercostal space. Now listen for the heart sounds in the APTM area we discussed. As long as you hear some heart sounds, in which I'm going to provide a simulated version of what is quote-unquote normal for you in here, it's good enough. If you have a hard time hearing your heart sounds, hold your breath. Before you hold your breath, don't take a deep breath, as that inflates the lungs and increases the distance between the stethoscope and the heart.
Next, you'll want to repeat the exam with the bell of the stethoscope in the same areas as you did for the diaphragm. Be sure when using the bell of the stethoscope to just apply as little as pressure as possible to create a seal.
You're then going to repeat the cardiac exam with the bell of your stethoscope by turning it. Mine actually doesn't have a bell. Remember, in actual clinical practice, you might have to address the patient more.
Next, for pulmonary auscultation, you want to switch back to the diaphragm of the stethoscope. Instruct the patient to take a deep breath through their mouth on your command or each time they feel the stethoscope placed on their chest. Listen to each position through one full inspiration and expiration. As you can see, I'm auscultating on symmetric areas of the chest before moving to the next position. In the back, we're auscultating 3 posterior and 1 lateral position in an approximate L shape. Essentially, we're trying to avoid listening over the scapula. On the anterior chest, we're listening over the apices, which are above the clavicles. and one additional area on each side of the anterior chest.
For long auscultation, you're going to first turn your stethoscope back onto the diaphragm. Again, mine doesn't have a separate bell, it's just the amount of pressure I press. So first, you're going to imagine that you listened to the 6 spots on the back. Listen to left upper long field, right upper long field, left mid-lung, right mid-lung, left lower lung, and right lower lung in an L shape, skirting the scapula. And next, you're going to listen to the lateral parts of the lung. Then next, you're going to listen to the apices above the clavicles. Then I'm going to listen to the anterior lung. And then the other side.
When examining the abdomen, make sure you're standing on the right side of the patient and pull out the footrest as the patient lies down for comfort. Ask permission from the patient to lift up the gown and make sure you're able to see all 4 abdominal quadrants. For female patients, lifting the gown to the broad line should be adequate. During inspection, look for any scars, erythema, or guarding from the patient.
Do a self-exam on the abdomen. First, start by inspection. Inspect for any skin changes, any obvious masses, and any scars. I actually have an appendectomy scar through my umbilicus and one lower that you can hardly see. And then assess the contour of the abdomen. Is it flat, scaphoid, protuberant, or distended?
When palpating, start with superficial palpation with one hand and palpate with a light, gentle dipping motion in all 4 quadrants. Assuming there was no significant tenderness to light palpation, move on to deep palpation using 2 hands. Use the hand on the skin to sense the underlying structures, and the top hand to provide most of the downward pressure in a dipping, sliding motion.
The palpation of your own abdomen is somewhat difficult, but we'll give it a try. Start with light palpation. Right upper quadrant, left upper quadrant, left lower quadrant, and right lower quadrant. Next, do a deeper palpation by using one hand on top of the other, and then top hand's going to apply the pressure downward. Right upper quadrant, left upper quadrant, left lower quadrant. Once in a while you might feel a mass in the left lower quadrant, and that's probably just your stool. Right lower quadrant.
After helping the patient sit up from the exam table, let's move on to the extremity exam. We're going to be examining the lower extremities for pretibial edema, as well as dorsalis pedis and posterior tibial pulses. To find the posterior tibial pulse, first palpate the bony medial malleolus, then place your fingers just behind and below it. You may have to apply varying pressure to feel it adequately.
For the posterior tibial pulse, first make sure you're comfortable. I find that if I cross my legs, one leg on top of my thigh, it's a little bit more comfortable. Locate the medial malleolar protrusion. And then for me, I find that most people tend to go towards the heel a little bit. Kind of slide down. And feel around there until you feel pulsation. And you might want to practice marking with an X so you get a visual reinforcement of where the location is. Now I'm switching sides. Here's my medial malleolar protrusion. And then I'm going to run my hand behind it and down towards the heel. Apply varying pressure until you feel a pulse, sometimes a little deeper, sometimes a little lighter.
To feel the dorsalis pedis pulse, it may be easier to first have the patient extend the great toe. The pulse is usually found just lateral to the extensor tendon in the midfoot.
On the extremity exam, finding the dorsalis pedis pulse, first make sure you're comfortable. I'm sitting on a bench, but maybe you're more comfortable on 2 chairs on your bed so you can prop your leg up. Start by locating the great toe and just lateral to the tendon. This is kind of ropey material you feel. Go lateral to it towards the second toe and walk up. Usually at least halfway up before you feel the pulse, and an inch up until you feel it. And mine's right here where I marked it. I'm going to the opposite side again, the great toe. Then lateral to the tendon, walk up, a little bit at a time, inch up. And I feel it here where I marked it with an X. Sometimes, if you have a hard time, you might be pushing too hard. Lighten up on your pressure.
Pretibial edema is assessed over the bony tibia. Use your thumb to press down over the bony tibia for at least 2 seconds. Observe and feel for any residual depression that remains.
For lower extremity edema, you want to find the shin, which is the tibia, and on the medial aspect of it, there's usually a nice flat surface for you to push your thumb against. And push for a few seconds. And then you see mine has a little bit of indentation. Now we're going to switch sides. And you're going to feel the indentation.
Assess strength by asking the patient to put their arms in front of them and push and pull against your resistance. Next, have the patient lift up your thigh against the downward pressure of your hand on their thigh.
The neural strength exam is a little difficult to test on yourself, but here will be the mechanics of doing it. Hold up your arms and push against one arm and pull in against the other. You get a sense of the amount of resistance you need to apply. Then next, for the hip flexion test, lift up and don't let yourself push yourself down. And then go to the opposite side. Just get a sense of how much resistance you need to apply to push.
Finally, have the patient walk across the room and back and observe their gait.
As for the gait exam, watch yourself walk across the room and back in the mirror. And this concludes the self-exam modification of the core exam. Again, if you have opportunity to practice the core exam on other people, please do so. In the meantime, continue to practice on yourself so you can start to develop your hand skills, motor skills further, that you understand what a normal exam is like, and that you get acquainted with the tools of the trade. Thank you.